Hey, good morning. So glad to be back with you again. Grateful for the opportunity to be with you this morning and have you as part of our growing family of listeners. We're going to start today with a pretty serious topic, and that is chemotherapy. When your doctor says you have cancer, one of the many fears that comes to mind is often the effects of chemotherapy. In fact, some people fear the chemo as much as the disease itself. Well, we're going to tell you this half hour that some of those fears are no longer necessary, that the process of going through chemotherapy is much, much different than it was many, many years ago. And we're going to learn more about how that's changed and what you can expect from chemotherapy as we talk with Dr. Srinivasa Nattam, an oncologist with Fort Wayne's best-known oncology practice, Fort Wayne Medical Oncology and Hematology. Welcome back to the program.
Thank you, Lee.
Let's jump in and tackle the big elephant in the room, the one thing that everybody fears about chemotherapy, the most notorious side effect. Can you keep me from having nausea and vomiting in this process?
Yes, Lee, that it has been the most feared complication of chemotherapy, namely nausea and vomiting. I hate nausea and vomiting like everybody. I got sick, so I understand how bad it is. Well, when I first joined practice here in 1981, we didn't have many drugs to prevent the nausea and vomiting. I remember so many people used to get sick. We used to hospitalize them. Thanks to the understanding of the pathogenesis of nausea and vomiting occurs. So early 90s were the major breakthrough in developing drugs to prevent nausea and vomiting. Since that time, I'll tell you, I can assure all of our patients that there's a very slight chance they get sickness anymore, the nausea vomiting part. Well, we still have to deal with the fatigue part, and some patients develop low blood counts, they need transfusion. But the most feared complication of chemotherapy, because of which some patients fear to take the chemo, is no longer an issue.
Wow, that's great news.
Yes.
Yeah.
And since that mid-90s, after the first introduction of the drug called Zofran, we have other drugs which prevent the nausea vomiting even further. For instance, when it first came, we were able to prevent the nausea vomiting the day of chemo, the day after chemo. Then we began to notice, depending on the drugs used, some of them will come up with what we call delayed nausea, like 3 days later. That became a big issue for a few years. And then they invented another drug which will prevent that. So we combine both now. And as a matter of fact, the way we approach how to prevent nausea and vomiting has changed. So we look at chemotherapy, less chances to develop nausea, moderate chances to nausea, and in more higher chances. And we give the anti-nausea medications according to that.
So that's great news. At least one less thing to fear.
Yes.
Is there any solution to losing my hair? Is that still going to happen?
Unfortunately, there is no solution for that. In the early years of my practice, we have used this ice package of the head with a
or cooling cap or something.
Cap.
Yeah.
Then we learned that it's very uncomfortable, it's very painful, because what the ice does is reduces the blood supply to the scalp, and it causes ischemic pain, and we don't have any answers, and so we just have to tell the patients that we have to deal with it. Now, there have been tremendous improvements in developing the wigs. So when I first came, the wigs were not that sophisticated. Now, when we see patients that are about to receive chemo, that they're going to lose any hair, so we ask them to consult these places where they can match the wig to the hair they have.
Oh, good. I didn't know that was available. So one of the reasons that you lose your hair and that you are nauseous is because the chemotherapy drugs are designed to attack cells that are growing and replicating quickly, right?
Yes.
So your hair, the lining of your GI tract, and your mouth and other places like that are cells that are reproducing quickly. And that, of course, is what makes cancer so dangerous, is it's growing uncontrolled. So chemo works by attacking those cells. And it doesn't understand that it's only supposed to attack cancer cells, so it's hitting all those fast-growing cells in your body. So that's the basic principle by which chemo works. When am I going to receive chemo? Is the type of cancer I have, does that determine where in the process chemo is going to appear?
Yes. Yes, you're right about the side effects of chemotherapy. Chemotherapy is empirically designed. It was invented based on the understanding that cancer cells multiply faster than the normal cells. So when the chemotherapy drugs were introduced, essentially they were introduced to inhibit DNA replication. So you can call in layman's words DNA poison. That's why some people call chemotherapy poison.
Right.
Well, so that means chemotherapy kills the cells that expose the DNA. So the resting cells in our body, like the skin, like the bones, like the liver, are not affected. So in our normal cell, there are several areas where the cells multiply faster than cancer cells. That's the cells that make the hairs, cells that line the mucous membrane of the mouth, and the blood cells. They have to replicate faster to maintain the normal structural function of those cells. So those are the cells affected. Well, how do we manage this? Well, we manage this by giving chemotherapy when it is indicated. And the chemotherapy is like you asked me, chemotherapy is designed, the type of chemotherapy is designed a little bit different for each cancer. There is some common drugs for many cancers, but we learned over the years by clinical trials, certain drugs work better for certain cancers, and the chemotherapy is given in certain frequency. So majority of the chemotherapy drugs are given every 3 weeks. So the side effects are first 1 week, and then they have 2 weeks to recover, during which time the normal cells will repopulate.
So that might explain why Rush Limbaugh is off the air for a week at a time when he's in treatment, and then comes back and he sounds pretty good, like he's got his normal energy levels in weeks 2 and 3. And then that's how typically patients are experiencing it.
So that's why chemotherapy is not given every day. Majority of them given every 3 weeks, and there are some given every week. But if you look at most of the chemotherapeutic regimens, they are given every 21 days. So you have 1 week, you're a little bit tired, your appetite is down, you may have to take more rest, but then you have 2 weeks to recover.
And welcome back to the program. We're talking to this half hour about chemotherapy and what you don't know about chemotherapy. And if you don't know a lot about it, I guess you're a lucky person, right? It means it hasn't visited your family. But Dr. Srinivasan Nattam from Fort Wayne Medical Oncology and Hematology is our guest today. So if you have a question about chemo, he can take it for you. I want to talk a little bit, Doctor, about where chemo comes in the sequence, because the type of cancer I have determines how soon or what type of chemo I'm going to be receiving.
Yes. Even though we have made a lot of advances in cancer treatment, we are in the personalized approach to cancers. Chemotherapy is not going to go away in the near future. So chemotherapy is needed for many solid tumors. So for some cancers, chemotherapy still plays a big role in actually cure. These are blood cancers, we call it hematologic cancers, acute leukemia, we need chemo, lymphoma, we need chemo, and some of the solid tumors like lung cancer, common cancer, breast cancer, and colon cancer, and cancer of the ovary. Chemotherapy is still first-line therapy. And in many cancers, you prolong the life, you make their quality of life better, and some we cure. For instance, Hodgkin's disease is rare, but it is cured primarily with chemotherapy today.
And in other cases, chemotherapy is used to kind of mop up and after surgery. So you remove as much of the tumor as you can, and then chemo is left to clean up.
Yes. In late 70s and early 80s was the first time the concept of so-called adjuvant chemotherapy was introduced. The word adjuvant means in addition to surgery. So it was recognized. For example, a common cancer like breast cancer, this is the first cancer where they introduced adjuvant chemotherapy. Some of the patients after surgery looks like cancer was just in the breast, localized. This shouldn't recur. To our surprise, 30 to 40% of them came back with the chemo. Well, once the cancer occurs, breast cancer is not curable. So the adjuvant chemotherapy was introduced using the concept you can kill the cancer when it is invisible. So that's what adjuvant. So we use for breast cancer, lung cancer, colon cancer, just to give some examples.
And we haven't really seen a lot of new chemotherapy drugs. Isn't that kind of interesting?
Yes.
That they're kind of been the same for about 10 years now.
Very good point. We reached what we call a plateau in chemotherapy. In fact, I'm trying to remember, it has been probably almost 2 decades since a new chemotherapy drug was introduced. So since we reached the plateau, we went back to the basic science bench, and now we're trying to find out new ways of killing the cancer, and that's where the targeted therapy and immune checkpoint inhibitor therapy were introduced.
So personalized medicine is a phrase people are going to hear more about. Tell me how that works, where you're really kind of tailoring that treatment to my particular cancer.
Right. So because we reached the plateau with chemotherapy, we went back to the bench and looked at the basic sciences, trying to understand how does cancer grow and how do the cancer cells develop resistance, and why can't we kill all cancers with chemotherapy. Then we understood that majority of the cancers have some mutations, and that's what drives them. So the term oncogenes were introduced. Tumor suppressor genes were introduced. And thanks to the advances in molecular biology, now we have found out in many cancers there are mutations which drive them, or some activation of pathways. It shouldn't be activated, because of which they grow. So we know what the Achilles heel of the cancer, and now develop targeted therapy. And for some cancers, it made a huge difference. I'll give you an example. A common cancer called breast cancer. In 1990s, there was a major breakthrough of developing first targeted therapy called Herceptin. It only applies for 25% of the breast cancer patients. 2005 was the magical year for breast cancer patients who were HER2 positive. Until that time, there was no good therapy. So in 2005, FDA approved Herceptin in the adjuvant setting, and it was a big news, a breakthrough news, because 50% improvement in survival and cure. And in 2000, they introduced targeted therapy to treat a rare cancer called chronic myelogenous leukemia. Today, chronic myelogenous leukemia became a chronic disease with the introduction of the targeted therapy, another huge breakthrough. With those developments, there is a hope that all cancers are treated using this precision medicine. And we then realized that even with targeted therapy, they develop resistance. Then another area of research called immunobiology, where they found out how cancer cells live in what's called privileged surroundings, where they make the normal immune cell help them grow.
Yeah, isn't that interesting? So they trick your immune system into being so they're kind of invisible.
Yes. So it is expected that the immune system recognizes cancer cells are foreign and the T cells should be activated to fight them. Well, somehow cancer cells found out how to turn off the T cells. We all have a mechanism by which your immune cells are turned off so they don't become overactive. So cancer cells take advantage of that mechanism and secrete proteins to turn them off. So, thanks to this understanding in immunobiology, now we have developed monoclonal antibodies to disrupt this and stimulate the immune cells. All of a sudden, immune cells recognize the cancer. It's I tell patients like this. It's like there is a camouflage on the cancer cells. With the antibodies, we remove the camouflage. All of a sudden, T cells see this. And luckily, it has no side effects because they don't attack the normal cells, except in about 5 to 10%. These activated T cells attack the normal structures.
So we have just a couple minutes left. There is the belief that in a mid-sized city like ours, that you're not really getting the best of cancer care and you're better off going to outside sources. Tell me what I need to know about the quality of cancer care that we can receive here. Are we up to date? Is it as modern as it can be anywhere?
We are very up to date. I'm very confident. We are very confident. We can take care of almost all cancers. Majority of the times, you don't need to go anywhere. All treatment are available. We use a multidisciplinary approach. We're using tumor board. Our ability to cancer diagnosis has significantly improved. Our radiological techniques are very advanced. Every type of CT scans, MRI scans are available here. All treatments are available here. Well, admittedly, for a community center like this, there are few things we have to send them out. For instance, are all stem cell transplantations. They're not available here. They are typically done in a tertiary care, a university hospital like IU Medical Center, to give an example. And there is a new form of personalized medicine called CAR T cell. Maybe you heard this.
Yeah, CAR T cells.
So basically, this is a cellular immunotherapy where you take your own T cells, engineer them in a laboratory, and attack the cancer cells. This is very effective. We do this when other treatments fail, and at this point in time, it's not a treatment done in any community care. Other than that, all other treatments are available.
You have seen thousands of patients through the years. What stands out as a factor that is going to help me get through my fight with cancer? Is there something about my mental attitude, my approach? Does that really matter?
Well, mental attitude matters once you have diagnosed, and because many patients become very anxious that they have to deal with the treatments and side effects. But for a general person, the only thing that you can do to help decrease your chance of cancer is mainly, how you take care of your life in general, like other good health attitudes like weight reduction, do not smoke, and the usual healthy habits that would reduce the incidence of cardiovascular disease also apply for cancer.
So I love to ask doctors this question. I think I may have asked you the last time you were here. Is there anything with all the patients you've seen, all the information you have consumed over the years, is there anything you do differently and manage your own personal health to reduce your risk of cancer?
No, I don't do anything different than what I just mentioned.
Just healthy living.
Healthy living is I cannot overemphasize that. Because there are some cancers that occur that have really nothing to do with your healthy living, like acute leukemia and a few other cancers. So you can do much for them anyway, but what you could prevent is the more common cancers like lung cancer. And of course, you also follow the recommended screening techniques. That's how you find the cancer early stage and treat them. Good examples are colon cancer, breast cancer, don't forget cervical cancer.
That's good advice. Thank you very much. That's Dr. Srinivasan Nattam with Fort Wayne Medical Oncology and Hematology. You will find them online at fwmoh.com. They also see patients in multiple cities around the area, making cancer care as convenient as possible for you.